So I'd like to introduce our speaker tonight. So Dr. Brujic is a 2002 graduate of the New England College of Optometry. He is a partner of the Premier Vision Group, a successful four-location optometric practice in Northwest Ohio. He practices full-scope optometry with an emphasis on ocular disease management of the anterior segment and specialty contact lenses. And he is active at all levels of organized optometry. Dr. Brujic is on the editorial board for a number of optometric publications. He has published over 400 articles and has given over 1,900 lectures, both nationally and internationally, on contemporary topics in eye care. He also has an amazing podcast called Optometric Insight. So please be sure to listen to that, and you'll get to hear a lot of great topics. Here are his financial disclosures, all of which have been mitigated. And I will have you go ahead and take it from here. Thank you so much.
Great. Ariel, thank you. And all of you, thank you so much for joining us this evening. This is going to be a fruitful discussion, in particular if anterior segment is your passion. And I do have to start off the discussion this evening by sharing with you all why I really want to deliver this information this evening. So I know that most of you are looking at me and probably thinking, well, wait a second, this guy's a recent grad. The 2002 thing doesn't make sense. I'm 47 years old. It is true. But when I graduated optometry school, I kind of always remember even being in classes and when you first started getting into the clinics, and there was all of this, I don't want to say machoism, but there was this kind of thing where you'd always kind of come back from clinic and you'd want to share with your classmates the cool, rare thing that you saw. And then there'd always be somebody else that saw this cool, rare thing that they always kind of felt like they were trying to up you. And the question I always asked people was, oh, so what did you do to manage it? And they say, oh, we had to refer it out. Oh, what did you do with this weird kind of retinal pathology that you saw? Oh, we had to refer it out. And the thing I saw from optometry at that point, and this was prior to the advent of many of the pharmaceuticals we have access to today, or many of the technologies we had today, the thing I loved about optometry was the fact that we could manage and own the anterior segment. I've always felt passionate about the anterior segment in the ocular surface because, again, this is really our space that we can own and manage truly from start to finish, unless there's some type of surgical procedure. But as most of us know, we're starting to do more procedures in our office. We're starting to incorporate more technologies. And because of that, we have truly become the experts in monitoring and managing anterior segment conditions. And that's really the impetus behind this discussion today. So we're going to be talking about OCT. We're going to be talking about anterior segment advancements. But I always think it's important to understand where we started and why we started this journey, because when we go back to 2006, which is when we got our first spectral domain OCT in our practice, we realized something very, very interesting. We were at the time taking central corneal thickness for patients who were ocular hypertensive patients or glaucoma patients using an ultrasound probe. Now, the reality is that probe needs to be perfectly perpendicular on the surface of that cornea. And the reason is because all of these instruments that we're going to be talking about tonight are kind of dumb instruments. They don't know what they're doing. We have to interpret that data or that information. It just simply sends out a signal and it measures where that tissue starts and where that tissue stops. If you're perfectly perpendicular, you can hit it right on and you can get an exact CCT or central corneal thickness. But if you're off just a little bit, you actually overestimate the thickness of the cornea and you put that individual in a category of lower risk, assuming that they have thicker corneas, when in actuality, the probe just isn't lined up appropriately. We saw this early on because a lot of these probes were measured utilizing, and again, you'd take multiple measurements and then you'd take the three lowest measurements in a row, and that would be the measurements that you would take and you would record in your chart. Well, we realized very quickly that we could do this better. But we started finding some things out at that time. So again, this is 15 years ago. And when you look at this pachymetry scan, you can already see something looks terribly fishy about this. So again, this isn't a topography. This is a pachymetry scan. So we're looking at corneal thickness. The green represents thicker regions. The blues represent thinner regions. But what you can see is that there's this thinner region down here. As I started investigating this more, I realized that these thinner regions actually meant something. These metrics that we're looking at on the ocular surface and that we're measuring, and all of these numbers that come up from all of these measurements mean something. And there was a pivotal paper that was published in 2013 that really gave us the answers to what it actually meant. It actually looked at optical coherence tomography-based pachymetry scanning and scoring that and determining based on nothing more than a pachymetry scan, somebody's level of risk of having keratoconus. And this is a table directly from that study. And it looks at all of the metrics that we were just talking about. So I want to go through each one of these as an example. So let's go over this first metric right here in the table, SN minus IT, which stands for superior nasal minus inferior temporal. This first line right here, you can see all of these numbers, and you'll see what those mean in just a moment. But each one of these numbers or ranges of number have a risk score that's associated with them along the top of this chart. So when we look at our OCT scan and we look at this patient, for example, and we see the thinning that's occurring here, we look at this metric, SN minus IT. And in this patient, the superior nasal region minus the inferior temporal region is a 75. So when we go back to our risk table and we assess it, we go to this first line, 75 is greater than 51. So we automatically get a grading or a risk score of 3. Now, what's going to happen is for most individuals, you take all of these 5 metrics, you add them all up. And if you have a score that's greater than or equal to 4, you have a high risk of being a keratoconic patient. So we're already at a 3 with 1 risk factor. So let's now look at the minimum corneal thickness. Well, that's denoted right here by this blue star. We know that this is important when we're dealing with vision plans because certain vision plans utilize minimum corneal thickness as one of their guides to determine whether or not you're dealing with a moderate to advanced cone versus a mild keratoconic patient. Discussion for a totally different time. But it's 440 microns here, you can see on the left-hand side. Well, when we put that back in our grid, we can see that it's less than 455 microns. We already have a risk score for that second factor of 3. We're already at a 6. If you have 4 or more, you have a high risk of having keratoconus, and we are already at a 6. This is already telling you that this patient is a high-risk patient for having keratoconus. It's interesting, again, as technology evolves, they're starting to justify the hypotheses that we used to have in these individuals. And the reason why I say that is I still remember in my 3rd year, I did a paper on keratoconus, and I remember researching the pathophysiology. And we oftentimes think about keratoconus as this misshapen cornea. But the misshapen cornea in keratoconus is nothing more than the downstream sign of keratoconus. Keratoconus in and of itself is a corneal thinning disease. Again, the physical manifestation is the outpouching of the cornea, usually in the region where it is thinner. Now, we've evolved, and over the last 20 years, we've seen massive changes in the contact lens world. For those of you that are graduated in the last 5 years or so, you're in a great position because you have these technologies that are available to you that we had to cut our teeth with 10, 15 years ago to get them to the level where they are right now and the predictability where they are right now. It's interesting, though, when we talk about scleral lenses, because scleral lenses are based on certain principles that are different than small diameter GP lenses, and that is this concept of sagittal depth. Sagittal depth describes nothing more than the depth of the bowls of the lenses. This is something that we don't really commonly talk about in soft lenses and GPs, although I would make the argument that we should. We don't typically. One of the metrics that we think about is base curve, and we don't really think about those metrics when we are thinking about a scleral lens. Now, when we're fitting a scleral lens, we're fitting it utilizing 3 basic principles. 1, appropriately clearing the central cornea, or the portion that's most closely coming to the cornea if it's a keratoconic patient. The second is appropriately clearing the limbus. And the third is having appropriate landing zone characteristics. Let's dive into this a little bit more, because when we're talking about the central corneal clearance, ideally what we want is a central corneal clearance between 100 to 300 microns. That's what we're ideally looking for. And if you were to ask me, well, wait a second, Scleral lenses settle on the eye throughout the day. They do. Well, then what's your ideal clearance? My ideal clearance is when I put that diagnostic lens on, 5 to 10 minutes later, when we're normally assessing OCTs, I want it to be 300 microns, because if it's 300 microns when you first put it on, so that's going to give us a perfect buffer for that landing zone settling down. And it's going to give us a perfect buffer where we're not going to be touching the cornea anymore. Now, this is how we used to assess central corneal clearance. We used to fill the bowl of the lens with fluorescein. We used to look at it at a slit lamp, and we used to compare the thickness of the scleral lens to the thickness of this fluorescein pattern that we see really entrenched between the posterior surface of the lens and the anterior surface of the cornea. Well, OCT has evolved the way we do this, and this has added such a level of precision to the fitting that nobody should be overvaulting patients at this point because of the information that the OCT actually gives us. And this is just one example. With measuring calipers, you can measure whatever part of an OCT scan you'd like. What I did here was I measured the the thickness of the lens, the thickness of the cornea, and also the vault of the lens over the anterior surface of the cornea. This is an example of the lens settling over time, and we know this is going to occur, and we see that this keratoconic patient, these are both vertical scans taken through this patient's cornea, and you can see the scleral lens, you can see the clearance, and you can see the cornea here, and you can actually see at this point right here, it goes from 288 at the beginning of the day to 179 at the end of the day. So you can see that settling, and that's expected. Now, I presented one of the, what I would argue is the most humbling posters that anybody could present at Global Specialty Lens Symposium several years ago. And I looked at this and I said, has anybody compared their ability to estimate central corneal clearance at the slit lamp compared to an OCT measurement? The data just didn't exist. So I said, I'm going to compare myself. I want to see how good I am. And I'm actually going to put in a poster at Global Specialty Lens Symposium. So what I did was I looked at 5 consecutive patients wearing scleral lenses, and then we measured them at the OCT, and we determined how close or far away I was. Now, this is a summary, and this is the actual poster that I presented, but I'm going to jump right to the data here. I'll summarize it for you. I was horrible. I thought with an experienced scleral lens fitter like myself at the time, I had hundreds of fits under my belt at the time, and I was all over the place. I was overestimating. I was underestimating. I thought I would either be consistently over or underestimating. I was all over the board. And these are the second eyes on those individuals. So again, this was the first kind of wake-up call for me to say, I need to be doing this different for patients. Now, here's where the devil starts to get into the details, because central corneal clearance tells us scan. And you're looking at here is a vertical cross-section scan. You can actually see where the optic zone starts in this lens. And what you can see is, if you assume that the left side of this scan is the inferior portion of the cornea, and this is the superior portion of the cornea, you can see that this lens has dropped. It's sitting low on this eye. We know that because we don't expect to see the optic zone right here. This region of the lens corresponds to the superior pupil right here. Again, this is not something that we want to see. But what's something else that we see that's unique in this scan? Well, we actually see a substantial difference between the level of clearance superiorly on this lens than we do inferiorly on this lens. We can make a lot of assumptions about this. We know that this lens is sitting low because there's more clearance inferiorly. This is where you start to take the OCT and you understand it, and you start leveraging its ability to truly give you new insights into how these patients or how these lenses sit on eyes. Now, what I'm going to do is I'm going to show you several OCT scans, appropriate ways to assess them, some unfortunate, inaccurate ways to assess them. And I'm really going to highlight a lot of the clinical stuff that's important. Now, Why is this important? Well, we know that this lens is sitting low. We want it to be vertically centered appropriately for two reasons. One, if the optic zone is sitting low, these are patients that you may have put a scleral lens on before, and you're testing the vision and they're not getting to the level that you would expect them to. Oftentimes, that is secondary to a decentered lens, and recentering that lens will actually improve the vision for these individuals. But the second thing, and the second reason is, oftentimes the answer to an uncentered lens vertically resides in the landing zone characteristics. And we're going to talk about that as we get into that portion of the assessment. Here's another example of an individual. And again, you'll see that with my scleral lens scans, I have a lot of examples of what not to do because these are coming from my office as I'm fitting these patients. So you can see another example of a lens that's sitting lower than we would want it to because the inferior clearance is greater than the superior. Here's one where we're really kind of dicing into it and we're really making it what we actually want. So you can see here inferiorly and superiorly, this clearance is virtually identical. So what we've done with the landing zone manipulations is we've actually recentered that lens. And in doing so, we're probably going to provide this patient with the best visual optics outcome. Now, here's another important thing to note on this scan. See all this stuff down here on the bottom of this scan? So like you're seeing a pachymetry scan here, an epithelial thickness map here. This is all gibberish. Don't pay attention to any of this when you're scanning a scleral lens. The reason being, this is a simplistic tool with a high level of sophistication. What do I mean by that? This tool was never built to measure scleral lenses, and OCT was built to measure human tissue. What we did, this was 15, 16 years ago, and I remember the initial email threads that we had on this. One person said, hey, does anybody have anterior segment OCT, and have you tried doing this? Because you can actually see the clearance. So we repurposed this technology to do this. This is its software analysis, trying to kind of figure out how thick the cornea is, but it's way off because it's not meant to do it with a scleral lens in place. Here's where some massive advancements have occurred in the scleral lens world. And for those of you that are either starting to fit scleral lenses or have started to fit them within the past 4 to 5 years, this is where the benefits of us cutting our teeth with some of these early designs makes massive advantages when you're fitting these lenses right now. First thing you need to be aware of is that you always need to make sure that you're clearing the limbal region of these lenses, or excuse me, of these corneas. We always need to have it void of any excessive pressure. Now, how do you identify the limbal region? Well, when you look at the cornea here, you can clearly identify the cornea compared to the sclera over here. And when you look at this epithelium that overlies the sclera, or essentially the conjunctival epithelium, you can see that it looks different here than it does right here. So again, there are definitive differences that exist. But the question becomes, where's that limbal region? Well, it's a transition zone. So it's not something that's black and white. It's not something that you can draw a line and you can say, this is exactly where it happens. But there are anatomical cues where you can see where that transition is occurring. This is the first one that I'm going to highlight here. So you can actually see this little tiny blue line, or this triangular kind of tissue that's showing right here. That's your first kind of landmark where it's going to give you an idea of where that limbal region is. The second region right here is this portion right here. And the third one is this region. You see a transition in the epithelial structure right here and the epithelial structure right here. This region right here, you want to make sure you're clearing this and you're making sure that there's no pressure. So again, in this patient, we've done a superb job of clearing the limbal zone. And here's why this has become such an easier task for us with contemporary design scleral lenses. They have what I refer to as a dual reverse curve. And let me describe that exactly. So when you look at the landing zone, which is where that first arrow resides, you can see that if you just extended the landing zone into the cornea, you'd actually put excessive pressure in this limbal region. When you look at the second curve, you can see that there's an alternate trajectory for that curve. So you can literally see it's lifting. This is the beauty of contemporary designs. The addition of this one curve has changed the game, because where we once were so concerned about limbal clearance, we now more oftentimes than not, if we do have limbal clearance, we have excessive limbal clearance that we need to reduce or drop on these individuals. But then there's a second reverse curve. So that's the first one. But the second one happens right here, because you can see that if you were to just set the trajectory from this arrow right here, you'd have excessive central clearance. So in order to avoid that, you actually, or there's the incorporation of this second reverse curve. And in doing this, you adequately clear the limbal zone, but you also don't clear the central region of the cornea by too much. Because remember, when we're filling the bowl with non-preserved solution, that has a decay, that has oxygen permeability, or a lack of oxygen permeability. So we always want to keep it between that 100 to 300 microns. So now let's jump into the landing zone. And the ideal relationship is for the peripheral portions of the scleral lens to fit tangentially to the conjunctival surface. We don't want the distal portions of the lens being or digging into the conjunctival surface, and we don't want the heel of the landing zone actually putting excessive pressure on that conjunctival surface. And this is what this looks like practically in a schematic diagram. So if you have a scleral lens landing zone, and this would be the more proximal portion up here, or what we oftentimes refer to as the heel of the landing zone, and this is the toe of the landing zone out here. So again, think of that landing zone as a foot. You can see that we're trying to equalize the pressure along the whole landing zone. And when we look at the fit of a lens on the surface of an eye, we can see what happens when we do evenly distribute that weight. And you can see that the blood vessel, or the architecture of the blood vessels, are identical here as they are here outside of the lens. This is, for those of you who are old enough to know who Jerry Maguire is, this is the quan, this is the thing that we're absolutely 1000% searching for. Again, we don't want any alterations in the structure of the blood vessel. And I'd go as far as to say that if we didn't know that we were talking about scleral lenses, and I just showed you this picture, I would guess that most of us would think that this was just a standard soft lens being placed on the surface of the eye. Now, here's the situations that we want to avoid. We want to avoid something where the toe of the landing zone is impinging into the conjunctival tissue. Why? Well, initially, this lens will feel really good, but over time, a patient will describe the lens as feeling pressure or having pressure on the eye. Now, when you look at that with an OCT, this is an example of that fit. Now, how do I know that this lens is impinging? And this next part is super important to understand here. This region right here is not what we utilize or put a lot of weight in to determine whether or not the lens is impinging into the tissue. And here's why. Everybody can see this image shift, or this dark line that happens right here. I'm going to take the arrow away here just for a second. Remember what we talked about early on. We repurposed the OCT to give us the ability to measure scleral lenses on eyes. It was never designed to do this functionality. We as clinicians said, hey, we can repurpose this awesome technology to give us the ability to do that. But in doing so, we have to respect the limitations of the technology. That being said, everything's measured and then software analyzes it and it spits out an image for us. This part of the image right here is actually looking or going through a piece of plastic. This image right here is not going through a piece of plastic. So because of that, you just get a natural image shift that occurs. And this will always make it look like the edge of that lens is digging into the tissue. So I want you to try and avoid the temptation of looking out here to assess how this lens is fitting, because ultimately there's an image shift here that will distort your perception of what's happening. Where the real beauty and the gem of the OCT is looking at the approach of the lens into this region. And what you can see here is that, yes, in fact, there is too much pressure on the very, very outer portion of this lens, or in the toe of the lens right here, because you can see that this landing zone that's probably looks to me like it starts right here and it goes all the way this way. None of this is touching the actual conjunctiva. The only place where it's touching is right at the outer edge. So we know that when we call the lab, we need to take that toe and we need to lift it up a little bit so there's not as much pressure on the very distal portion of that lens. So again, we're looking at the approach here. We're making sure that it's clearing the limbal region. And we also want to assess the approach of the landing zone as well, too. So this is a picture of an individual, and I'm going to show this to you here first. And I want you just to, in this chat box, if you could, this might be a good place for like some responses here. I want you to put down if you think that this is a heel down response or if this is a toe down response in the landing zone. Okay, so everybody can see the blanching right here. I want to know if it's heel down or if there's more pressure in the proximal portion of the landing zone or toe down. And I want you to type that in the chat. Okay, so we got a mixed bag of responses going down here. We got about, oh boy, toe down is starting to win. Oh boy, oh man. So there's a lot of debate here. So let me share with you some of the things and how this can actually misrepresent what's happening at the slit lamp. So initially you look at this and you say, boy, this is a strong toe down response. And why do you say that? Well, there's a lot of blanching here. But when you look very, very closely, take a look at these blood vessels right here at the very outer edge. And you can actually see there's a lack of pressure out here on these blood vessels. There's a lack of pressure right here. But then there's an absence of these blood vessels out down here. And take a look at the impingement that's occurring here in the heel region. This is actually a heel down response in the patient. This is another example of a heel down response, toe up response. Again, you can see these blood vessels emerging right at the outer edge or at the distal portion of the lens. So again, if you call the lab and you tell them on this patient, this is a toe down response, they're going to lift that toe up and they're going to make this worse. This is actually a patient where you need to bring the distal portion of the lens slightly down to even the distribution of the weight of this lens on the sclera more evenly. This is another example of a patient where you can see the excessive pressure and exactly where it's occurring. And then you can also see this region right here where there's a lack of pressure out here, or when you look at the total landing zone area where there's a lack of pressure, which is at the distal portion of that lens or in the toe of the lens. So why do I say all of this? Well, there's ways that we can assess this at the slit lamp. And this is an example of that. You take your beam and you shine it on an angle towards the edge of the lens, and you can see the shadow that's occurring here. And this shadow is an indication of a toe that's up away from the surface of the eye. So how can OCT assist us in this process? Remember, I'm a clinician. I see patients on a daily basis. So all of these images that I'm sharing with you are from my patients. And unfortunately, not every single one of my scleral fits is perfect. And we're learning every single day from every single clinical experience. And what we have to do is sometimes put on diagnostic lenses that don't necessarily fit right. And even when we order the lenses in, they don't necessarily fit the way that we want to. You can see where this scan is. This is the temporal area of the patient's scleral lens. And you can see that this landing zone has a trajectory that we don't like to see. Excessive pressure here in the heel. And then you can see the toe actually flaring up. This is something that we do not want to see. And we need to bring that toe down to even the distribution of the weight in that landing zone. This is another example of a patient. And again, you can actually see it slightly elevated here from the edge of the underlying conjunctiva and sclera. But what's interesting, again, take a look at this image shift that's right here. It's such a prominent shift that happens, which makes this tissue out here very, very difficult to assess. Where we're seeing that this is an inappropriate fit is the fact that this lens is putting excessive pressure here, and then it's pulling itself away from the surface of the eye. So with all my examples of bad fits, fortunately, I have examples of good fits, which is kind of what I want to show you and what you're really striving for in the landing zone. And that's what you're seeing here. And you're seeing this as the patient's looking up. So this is the inferior portion of the lens, and you can see how evenly distributed the weight of this lens is and the pressure in the landing zone is. That's really what we're seeking for and searching for. This is, again, the nasal portion of both eyes. And again, you can see how flat and evenly distributed the weight is in that landing zone. That's exactly what we're looking for. You can see it in the superior region on this patient. And again, you can also see that the limbus is being cleared in both of these regions. This area right here is getting somewhat close here, but we still have adequate clearance that's present. And again, you can also see it in this temporal aspects of these fits. So that's what we're really seeking and searching for. Now, to give you perspective on when I guide my technicians on what to measure, on the OCT scans, we're usually taking central corneal measurements, and that's usually either a pachymetry scan in the center portion of the lens, or it's a cross-section through the center portion of the lens. And then what we do is we identify where the flat and steep meridians of the landing zone are located. And we actually guide the technician to do it at those regions or those angles so that they're measuring in the axis of the steep meridian of the landing zone and measuring in the axis of the flat meridian in the landing zone so we can understand what those fitting characteristics look like. Now, I'll share with you that OCT is evolving fast. If you literally just go to any show where there's OCT companies, what you're going to see today is different than what you saw 6 months ago or a year ago. 5 years ago, that stuff is almost totally obsolete with what's happening with OCTs and anterior segment. They now have the ability to do anterior segment imaging. They now have the ability to do meibography, and these are just simply two examples of these higher order technologies. They're now able to take full measurements of the cornea and the angles, and you can actually metricize a cord here. So what you're seeing here is the cord of 16 millimeters being taken right here. And when you have that metric, you can then measure the sagittal depth from that cord if you have a 16 millimeter lens, and you can take it right to the surface or right to the anterior portion of the cornea. And you see in this instance, it's a 3.93 millimeters or a little bit over 3,900 micrometers of depth. So if you're selecting a lens, you'd probably initially want to select a lens, if you have it in your diagnostic set, of 4,200 microns. The game of scleral lenses and fitting them successfully is changing so fast, and we're becoming increasingly dependent on those technologies. Now, we're going to take a massive shift. So I love scleral lenses for their clinical utility. We use them for patients with corneal ectasias, more specifically keratoconus, pellucid marginal degeneration, but also scarred corneas, individuals who've had herpetic epithelial keratitis with now irregular corneas. We also use it for patients with severe dry eye, usually autoimmune related dry eye with recalcitrant keratoconjunctivitis sicca. In addition to that, we use it for patients with other irregular corneas. For example, those patients with epithelial basement membrane dystrophy. These are game changers for a lot of these individuals. But we're going to take a shift over into now looking at disease state monitoring with anterior segment OCT. And the first thing I want to talk about is epithelial thickness mapping. Some of you may have this capability on your OCT anterior segment scans. Others of you may not have this functionality. So what is this? As its name implies, it physically measures the epithelial thickness on these individuals. So as you look at these scans, I want to decode a few things. On the left-hand side, you can see the total corneal thickness. On the right-hand side here, you can see the epithelial thickness map. We usually expect the epithelial thickness to be anywhere between 50 to 59 micrometers. So if you think about an average cornea as being about 500 to 600 microns, the epithelium is about 10% of the total corneal thickness, with the stroma representing 85 to 90% of that thickness. And again, you see that here in this individual or this patient. Now, the first question I had when we acquired the anterior segment analysis or the software analysis on epithelial thickness maps is there any type of association, or is there anything that I should or could be monitoring with my dry eye patients? So I started doing a search in the literature to see if there was anything that showed any type of association with epithelial thickness. And the first paper I came across was this one right here, the assessment of corneal epithelial thickness in dry eye patients. And I'll really take you to the summary of the findings here, or the results. And what they found here was that individuals with dry eye, when you compare them to a control group of non-dry eye patients, they found that the superior corneal epithelium was thinner in dry eye patients compared with normal subjects, whereas central and inferior epithelium were not statistically different. And when we think about that, it kind of makes sense, because if you have chronic dry eye disease, we know that some of these patients become incomplete blinkers. And we also know that much of the activity occurs repeatedly in the superior region of the cornea. And we know that acute inflammation causes swelling. We know that chronic inflammation causes tissue destruction. So it kind of makes sense that the superior epithelium may start to look different over time. So let's now look at another study that was published almost at the exact same time. And let's fast forward to these results. So this is a second study, independently published, and it said this study, based on very user-friendly novel anterior segment OCT imaging, indicates increased epithelial thickness in dry eye patients. So I want to repeat what our peer-reviewed literature is sharing with us. They just shared with us that we see thinning in individuals with dry eye compared to age-related normals. And a second study demonstrated that there's epithelial thickening in these patients. So the question I have for most of you is, why is this happening? Why is there such a substantial difference? And is there an explanation to this? And my argument is, yeah, there is a very, very logical explanation to this. And that is simply the patients that were recruited in the various studies were looking at individuals at different phases of the disease. For example, individuals who have early dry eye disease, where we know inflammation markers are high, oftentimes have this very, very obvious inflammation that's occurring and can be measured in the epithelial thickness maps. We've all seen these patients. They come in highly symptomatic. They're usually in their 20s or 30s. You look at the cornea, there's no staining. You look at the meibomian glands, there's not any substantial or significant disease. You look at the lid wiper epitheliopathy, and you may see some signs of it, but overall, the eye doesn't, there's no red flags in terms of the signs that we're seeing. And all we realize that we're dealing with in those individuals is a patient early on in the disease, because we know that dry eye early on a healthy cornea will actually be more sensitive to patients. We've all seen those patients that come in with massive amounts of corneal staining, and their chief complaint isn't uncomfortable eyes. Their chief complaint is, I don't see as well as I expect. And we know why now those individuals are less sensitive at times, because we know that dry eye is, in addition to an inflammatory condition, it's also a neurotrophic condition. When you compare patients who have had long-term dry eye to those individuals, who have more of an acute phase disease, or they're earlier in their disease process, we know that those individuals who have had it for longer periods of time have shorter nerves and less sensitive nerves. So let's take a step back. Why am I sharing all of this? Well, these two studies uncovered two very important things. If you have more chronic dry eye, expect to see epithelial thinning superiorly. If you see more acute phase dry eye, expect to see a normal or potentially a thickened corneal epithelium. So this, for example, is an individual who is recently diagnosed with dry eye, and you can actually see the variability in the thickness in this patient. And again, it's color coded, so you can see the numbers actually vary substantially, 53 in the center to 50 out here to 49, all the way up to 57 out here. In addition to that, you can also see the color coding maps and showing the substantial level of irregularity in epithelial thickness that's present in these patients. This is an example of an individual who's had chronic dry eye for decades. And what you can see here is just like the study showed. You can actually see thinned regions of epithelial thickness superiorly and more of a normalized epithelial thickness inferiorly. So when we started looking at epithelial thickness early on, we were curious clinicians. So we started asking ourselves, well, what does it mean when we see it in a corneal injury, and what does it actually look like? So this OCT cross section, for example, there's obvious exceptional corneal scarring that's present there. But is there any irregularities in the epithelium that we need to be aware of? And there certainly is. You can see it here above the scar, but you can also see it in the epithelial thickness map. And we started scanning patients like crazy to help us understand this better. And we started looking at our Fuchs endothelial dystrophy patients. These are individuals who, again, have an abnormally functioning endothelial cellular layer, which causes stromal swelling and clouding of the patient's visual acuity. Now, one clinical caveat is if you're ever taking central corneal thickness measurements and you see this kind of hyperfluorescent line on the endothelial surface, this is very characteristic. Although it's not pathognomonic for Fuchs endothelial dystrophy, you'll usually see patients with Fuchs have this hyperfluorescent line of endothelial cells that are present. This is another example of patient with Fuchs endothelial dystrophy. And the reason why we've started measuring epithelial thickness maps on these individuals was because we want to see if they're regular or if they're irregular. You can tell in this patient with Fuchs, and you can even see some of the corneal irregularities that are starting to be present here. You can see that hyperfluorescence in the endothelial layer in some regions more so than others. But you can see the epithelial thickness is irregular. We know that in some of these more severe instances or cases, you'll actually see epithelial edema as well too. Again, this is what I was talking about with that hyperfluorescent region on the endothelial surface layer. And again, you can actually physically see that occurring on the posterior surface of the cornea compared to this individual who's a more normalized cornea. It is a post-LASIK cornea, but you don't see that hyper fluorescence that's present there. You don't see that whitening that's present there. So the post-refractive surgery patients started to become kind of interesting to me personally because, you know, we've always wondered, why do we have these patients who've had LASIK and are gung-ho happy about the results? And why do we sometimes have these post-LASIK patients who are unhappy with their results? So we started looking in different places. You know, we'd measure corneal thickness, we'd measure topography, but the patients who are problematic patients really didn't look different than those individuals who didn't have problems. So we started asking the question, could the answer reside in the epithelial thickness maps? And this is an individual who had LASIK, who you can see epithelial thickening here centrally. And you can see in the total pachymetry scan where there's thinning centrally, but you can see this epithelial thickness map thickening here centrally with this patient. Again, this isn't early post-op patients. These are patients that have had LASIK a decade ago. So these are long-standing LASIK patients. This is an individual demonstrating post-LASIK ectasia, where you can see the region of corneal thinning here inferiorly. When you go to the epithelial thickness map, you can actually see a region of epithelial thinning associated with the cone here. You will sometimes see epithelial thinning, in the region of the cone or total pachymetry thinning. And sometimes early on in keratoconus, you may not necessarily see that epithelial thinning. And this right here, this region is thickened epithelium secondary to the treatment zone that was done. So where this really started to get interesting was with the post-RK patients. These are some of the most unique individuals. I've never had patients more understanding of their poor visual outcomes than RK patients. And it's justifiably so. When you think about the time when they had RK, it was totally experimental. They had no clue what long-term consequences were, but they were the individuals that were going to jump out of the plane with the parachute, and they were going to be the first one to do it. They weren't going to wait for other people to figure it out. They were going to try it, see if it works. And the consents that these individuals signed were crazy remarkable. But the interesting thing is that it's very rare that you have heavy complainers. When you ask them, they'll say, yeah, my vision's bad, but that's okay. They told me that was going to happen. With today's LASIK patient, it's a totally, totally different beast. But I started looking at these RK patients and I started wondering, we're examining these patients at the slit lamp. They look identical to, the people who had poor outcomes to the people who had good outcomes. We look at them on topography and they look the same. We look at them with total corneal thickness maps, and again, they look the same. So could the epithelial thickness maps actually give us any insights into this? So this is an example of an individual who had RK, and this is a longstanding patient. They come in to see us every year. And you can see here, there's a little irregular thickening out here in the epithelial thickness map, but overall in the central region where the pupil is located, it's pretty regular. And this patient says, yeah, I'm happy with my results. Don't need any glasses, don't need any specialty lenses or contact lenses, just use glasses for reading. Now, this is an individual who complains about nighttime vision issues. And again, we always just assumed that it was because of the RK scars, which may be contributing to it. But we certainly can't ignore what's happening here in the epithelial thickening or epithelial thickness maps. You can actually see regions where it's thickened here, and you can see how it starts to influence the visual acuity when the pupil dilates. This is another patient, exact same thing. They just say, doc, it's my nighttime vision where I have the problems with it. This is an example of another patient where they're starting to have more visual complaints, and you can see the islands of irregularity and how they're starting to encroach more so in the patient's central region or their visual axis. This is another example of a patient who's complaining a little bit more. So take a look at this just generalized thickening centrally here that's seen. And this is to date the thickest corneal epithelium that we have on file. And that is 73 microns thick centrally. So again, we expect it to be 50 to 59 microns. This is substantial. What's interesting is these patients do tremendously well in specialty lenses. I'm not sure exactly why. Even in the absence of significant uncorrected refractive error, and even in the absence of any type of visible topography irregularities, other than just simple flattening centrally, these individuals, you put specialty lenses on them, and when they have these thickened epithelial areas, they do remarkably well with them. The explanation, still unclear, but they do improve visual acuity-wise and just their subjective visual responses. Let's talk a little bit about orthokeratology, because traditionally when we fit orthokeratology lenses, what do? Well, we look at it at the slit lamp, we take pre and post topographies, and we determine whether or not those lenses are settled. We've leveraged the OCT to help us give additional information on that treatment zone, utilizing what we know about the epithelial thickness map. Now, for those of you who fit Ortho-K patients for myopia progression management, the goals are different than for the individual who may be an adult patient who's interested in orthokeratology and a means to correct their refractive error. And for those individuals that are adults that are looking to correct their refractive error without having to wear contact lenses throughout the day or without needing to wear glasses, uninterested in surgery, orthokeratology is an option. But what we'll sometimes hear from these patients is, yeah, doc, it's great, but at nighttime I get a little bit of glare issues. The good news is we can customize that treatment zone. So we can make the treatment zone larger. But for some of those larger pupilled patients, we run into certain levels of limitations. I include this because this is, in my mind, such an important tool that we just need to remember that we have in our back pocket. And that is brimonidine, which is the active ingredient in all of these agents. Brimonidine at 0.2, 0.15, and 0.1% is what's commercially available and available to us and our patients as alpha-GAN or alpha-GAN P. And brimonidine at 0.025% is what's commercially available over the counter as Lumify. Brimonidine does an interesting and has a unique mechanism of action. When I share with you that it's an alpha adrenergic agonist, but it reduces pupil size, that for most of you should be counterintuitive. Because if something's an alpha adrenergic agonist, we would suspect it to dilate the pupil. Phenylephrine, for example, is an alpha adrenergic agonist. It dilates pupils. So why does brimonidine do the exact opposite and prevent pupil dilation? Well, here's the beauty in its mechanism of action. Brimonidine is very specific for the alpha-2 receptor. Why this is important is this. When you're looking at any physiological response, including the iris dilator muscle, there's a nerve that has a presynaptic ending on it. It secretes norepinephrine into the cleft, and it actually binds to alpha receptors on the iris dilator muscle, causing it to dilate. As the norepinephrine builds up into the cleft, it actually causes a feedback loop onto that nerve ending that's dumping norepinephrine into the cleft. And the nerve or the receptor that it binds to on that presynaptic nerve ending is an alpha 2 receptor. So it literally tells the nerve to stop producing more norepinephrine. Well, the cool thing about brimonidine is it does this in a more direct way. So when we put it on the eye, it binds directly to the presynaptic nerve ending on the alpha 2 receptor, telling that nerve ending, hey, stop producing norepinephrine. And in doing so, it prevents that pupil from dilating, and the sphincter just simply takes over. So in low light levels, you don't get that pupil dilation. This is an awesome thing to keep in the back pocket for those patients. But one of the things I'll share with you, an easy test to do in the office, is put an individual in low light levels in the office, cover one of the eyes, and then have this eye exposed looking at a target, and shine a bright light in the non-viewing eye. That'll obviously constrict both pupils. And if they have a positive response to that test, they'll do remarkably well with these agents. In our clinical experience, light-eyed patients respond very well to Lumify as a preventing pupil dilation. And for those individuals with darker irides, you usually have to go to the prescription strength for these individuals. So how do we leverage this technology for orthokeratology? Well, we do pachymetry scans on these individuals, and we look at the epithelial thickness maps. This, for example, is a decentered treatment zone here. We want to take this and we want to lift this so that it's more centrally. This is another example of a decentered treatment zone. What we're looking for is epithelial thickness maps that look more so like they do on the left-hand side of this slide versus the right-hand side. And communicating with your consultants about this will get you the tools that you need to get those Ortho-K lenses modified. A few other examples: epithelial basement membrane dystrophy. We always assume that, oh, that's elevated epithelium. Epithelial thickness mapping has taught us that that is not elevated epithelium. It's elevated basement membrane that's causing the total of the basement membrane and the epithelium to elevate on the surface of the eye, but it doesn't necessarily cause a thickened epithelium. In a counterintuitive twist, epithelial basement membrane dystrophy actually shows thinning in those regions that are elevated on negative staining of the cornea. And then again, keratoconus, you'll oftentimes see this corresponding epithelial thinning at these regions or areas of the comb that are present here. And these are just a few examples of those. So with that said, I hope that everybody's just picked up a few clinical pearls along this discussion. Ariel, before we bring you on to take on just some questions here, one thing I would like to share with you, and it is important for the post-test for anybody that's taking that. In our experience with scleral lenses, we've actually found that because with scleral lenses, you're preventing access of a patient from getting to their cornea and rubbing their eye and potentiating some of the inflammation that occurs with corneal rubbing. We've actually seen keratoconic patients more stable in the presence of a scleral lens than without a scleral lens, which is pretty interesting. We haven't published any of that data yet, but it's really interesting as we're following it through.